Hello, my name is Carlos Brian Francia, and welcome back to another lecture video. Today we're going to be talking about skin cancer, treatments, how it presents on the skin, and also how it looks like under a microscope. So that's going to be very exciting. I spent the entire week reading books and looking at scientific articles, so it's going to be very exciting. I know that this image says the development of actinic keratosis, but in general, this is what happens when you have skin cancer. This occurs during normal skin cancer development. So the sun actually produces something called UV radiation. And UV radiation, that means ultraviolet radiation. There are three types of UV radiation that the sun produces, that being type A, type B, and type C. So UVA, UVB as in boy, and UVC. Now UVC is actually blocked. It's blocked by the ozone layer. So there's a layer in the atmosphere that blocks a lot of the UVC rays. And that's great because UV type C is actually very dangerous for the skin. So really the skin is exposed to UVA and UVB. Between UVA and UVB, UVA penetrates the skin deeply, as you can see here. This right here is UVA. And as you can see, the ultraviolet type A radiation penetrates deeply into the skin. And when that happens, UV type A produces something called reactive oxygen species. Reactive oxygen species. And this is bad. So these are the bad guys right here. Because these guys are actually going to start messing with the DNA of the cells. So as you can see here, we have the hydroxyl radicals, and these hydroxyl radicals are going to start attacking the cell, and they start breaking down the DNA, and they cause further mutations. In contrast, UV type B does not penetrate as deeply as UV type A. So this one is not as deep. However, it does have a direct effect on the skin cells. So the skin cells that we're really concerned with in this case are the keratinocytes. And normally, as you can see right here, these keratinocytes are going to go upwards, and then they're going to kind of form the stratum corneum. And what you see as the stratum corneum is just the dead keratinocytes producing that keratin, the very hard fibrous protein that protects our skin and gives waterproof properties to our skin. For UV type B, we have a direct damage to the keratinocytes. So UV type B is going to go into the keratinocytes and start messing with the DNA directly. That's in contrast to UV type A, which creates the radical right here, the reactive oxygen species, and that itself is responsible for the DNA damage. UV type B directly enters the keratinocytes and starts causing DNA damage directly. So that's always going to be on exams. You have UVA, UVB, the reactive oxygen species. What you see with UVA causes the DNA damage. And then UVB enters directly into the cell and starts causing damage. And that's always going to be tested. But now we have to ask ourselves, when are we exposed to high levels of UV radiation? We're exposed to high levels of UV radiation, especially UVA, when we have tanning beds. And also whenever you have tanning solutions, like you see some company, they sell a spray that you spray on your skin, and that makes the skin more vulnerable to those UV radiation, and then you get a tan. So tanning beds and also tanning solutions. And I do not like them because they increase the rate of skin cancer. So they increase the risk of having skin cancer because they allow the skin to be more accepting of that UV radiation. But why do we care about UV radiation so much? I mean, how does that cause skin cancer in the first place, aside from the reactive oxygen species? Well, it causes skin cancer because it starts mutating something called a p53. And p53 is a tumor suppressor gene. So whenever the cell is developing, it needs to have a signal to stop developing, and it needs to have a signal that induces cell death. If the cell does not have a signal that induces cell death, then the cell is going to keep surviving and is going to keep making replicas of itself. The p53 allows the cell to die, and it controls if the cell develops or if it stops developing. So a lot of cancer, and not just skin cancer, but a lot of cancer, they have a mutation in which the p53 tumor suppressor gene is absent or is not activated. As you can see on the left-hand portion of this image, the more radiation that enters these cells and the more damage these cells have, the higher risk we have of p53 mutations. So this cell right here has a mutation inside the p53 tumor suppressor gene, and you can see that the activity of p53 is decreased, and that increases the risk of having skin cancer. Another gene that we have to pay attention to is something called the CDKN2A. And much like the p53 tumor suppressor gene, it also aids in the suppression of cancerous cells. So it allows the cells to induce cell death, and it limits the replication of cancerous cells. So p53 and CDKN2A, those are tumor suppressor genes, and they should be in your mind when you're thinking about skin cancer or just cancer in general. So these guys are always going to be tested on exams. And before we move any further, I want to mention something very important about CDKN2A. When we talk about cancer, specifically skin cancer, you always see a mutation in this CDKN2A gene. You see mutation when you have a basal cell carcinoma or squamous cell carcinoma, and even melanoma. You also see a mutation in CDKN2A with a colorectal cancer. So it's a very important gene to keep your eye on, especially if you go into cancer research. You'll always be talking about CDKN2A and p53. Going back into the discussion of ultraviolet radiation, when we talk about basal cell carcinoma, that arises from the basal layer of the skin. So here we have this nice basement layer, and that's called a stratum basale. And here you're going to have a lot of mutation within the keratinocytes, and then they're going to start going upwards. So because you have this mutation inside the tumor suppressor genes, and you also have damaging to the DNA of the keratinocytes, they start rapidly dividing and they rush into the upper layer of the epidermis. And in fact, the reason why we call that basal cell carcinoma is because right here we call these guys in the stratum basale the basal cells. We call them basal cells. And so there is a mutation within the basal cells themselves. And that arises because we have a overwhelmingly amount of UV radiation. Specifically, we can be talking about UV type B. UVA also contributes to this cancer formation, but UVB is one of the main sources. And again, you get that from the sun. UVA, it is produced by the sun, but you have a higher concentration of UVA when you have tanning beds. When we talk about basal cell carcinoma, you see this within individuals who work on outdoors for a majority of their life. So they have a very chronic exposure of ultraviolet radiation, and they get UV type B radiation from the sun over years and years of their lives. But we have to realize that in some parts of their body, there might be some cancer growth. Like for instance, there might be a cancer growth behind their thigh, and the thigh is almost always being covered by pants. So yes, you do have an increased risk of developing skin cancer when you have ultraviolet radiation exposure, but you also have a chance of developing skin cancer in areas that are not exposed to UV radiation as much. So you always have to do a full body examination for those individuals, especially if they have, let's say, a lesion on their arm, a growth on their arm. It's good to kind of get them in a private room and to check their entire body, and that includes areas below the waist, in a very professional manner. So just keep that in mind when we talk about cancer. We're not just talking about cancer that is exposed to the sunlight, but we're talking about cancer that is in their body. You have to do a full body examination for those individuals. So keep that in mind. These images that you see before you were acquired from a website called DermNetNZ.org, and that is a dermatological website based in New Zealand. I'm not affiliated with this DermNet NZ. I'm not looking to make any money off of this video. This video is intended for the education of medical students or for anybody who is in a health profession, just to educate and to raise awareness for skin cancer. This video is not intended to make a profit. This is a non-profit video. It's just an educational video. And I'm not affiliated with the University of Michigan. I'm not affiliated with any dermatological websites, and I'm not looking to give medical advice for individuals who have skin cancer. I'm not telling them to increase their medication or to decrease their medication. This video is just intended to educate others about skin cancer, the presentations, and different treatment options and how the medications work for reference when they study medicine or study for STEP. So for legal reasons, I have to mention that. I'm not a doctor, I am a medical student, and if you suspect that you have skin cancer, I highly, highly, highly recommend that you speak with a licensed medical professional. Alright, so we shall continue. And this is how basal cell carcinoma presents clinically. Right here, we can see that almost a common feature of basal cell carcinoma is that there's redness of the skin. We also have these rolled borders. You can see that the lesion just means growth. The lesion is raised on the skin, and then it's going to have these little rolled borders right there. So we can have rolled borders, and we can say that is indurated. Indurated just means raised. We also notice that it is shiny, it's glossy, it's pink. So we have glossy, pink. It also kind of looks waxy, like you dripped a lot of candle wax on top of the lesion. It looks shiny and waxy, glossy and pink. The borders, as you can see here, they're irregular. This one right here, it looks like a circle, but this isn't a nice shape. In this region, this is not a nice shape. So for the majority of the time, as we can see here as well, these borders are not even. They are asymmetrical borders. And that's a lot different from melanoma, because melanoma, you have different colors and it's not as red. Melanoma has like a darker brownish color for the most part. But for basal cell carcinoma, even though that this lesion is not raised, it does have an irregular border. It's red, and then you can see some dark staining. So that's not melanoma, but it's actually basal cell carcinoma. And for this individual here, it's a lot more difficult to see that lesion, but that lesion also has an irregular border. It's not glossy, but it is kind of pink and red. So if you see something like this, or any of this, these images, it's really imperative that you would refer them to a dermatologist. Like, let's say you're working in a hospital and you're talking to a patient and you see something on their skin and it looks really suspicious. Well, you would recommend them to see a dermatologist, or you would call somebody so that they can get a dermatologist and have a consultation with that patient. Also, some basal cell carcinomas, they're going to have something like an ulcer. So an ulcer is like a little a wound inside the middle of the lesion. And whenever you have ulcers in general for cancer, skin cancer, ulcers equal bad. So this guy is going to be more aggressive. More aggressive. And usually they tend to develop quickly, and they tend to spread on the dermis, the epidermis, in a rapid fashion. But for basal cell carcinoma, it's a very treatable cancer. So this is actually the most common skin cancer. And the risk of metastasis, we're just going to call that the risk of metastasis is very low. Yes, they do cause damage on the region, so this might kind of spread over here but it's not going to travel, let's say, to the lungs. It's not going to travel to the brain. There's a very rare instance of metastasis for basal cell carcinoma, so you don't really see that for basal cell carcinoma. And it can be treated using surgical incision, or you can do topical medication. And we'll talk about topical medications in a little bit, but that's some of the ways that you can treat basal cell carcinoma. And before I forget, I also have to mention that when you're looking at skin cancer, specifically for basal cell carcinoma and also squamous cell carcinoma, you have these fine little vessels, these fine little capillaries running along the growth. And that is actually called telangiectasia. Telangiectasia. And all that means is that you see a fine collection of capillary and blood vessels running along the growth. But why do we have this collection of blood vessels? Well, whenever you have an excess amount of cells accumulating on the surface, they require more nutrients, they require more oxygen. They produce more waste, and that waste has to go away, and it has to travel inside those capillaries. So the body increases the amount of blood capillaries inside the area so that the cancerous lesion can have more nutrients and more oxygen. So whenever you're looking at lesions and you kind of look at a person's skin and you see these fine collection of blood vessels, that's very suspicious, and that is actually telangiectasia. When a patient has a suspicious growth on their body, a dermatologist will often look at that growth with a special type of magnifying glass, and this is called a dermoscope. A dermoscope just allows the dermatologist to kind of zoom in on that growth and to see those fine details, and oftentimes it will help differentiate between different cancers. So it might tell the difference between actinic keratosis and squamous cell carcinoma, but you have to be a trained professional to really see those differences. And between actinic keratosis and squamous cell carcinoma, it's very difficult to kind of tell the difference, and we'll talk about that later. But they perform something called a dermoscopy, and whenever you perform a dermoscopy, you have these images of really zoomed in features of those cancers. So now we're going to be looking at some dermoscope images of basal cell carcinoma. And these are the dermoscope images of basal cell carcinoma. So oftentimes basal cell carcinoma doesn't have to be raised on the body. Sometimes it can appear flat. And it is uncommon to see basal cell carcinoma with pigment. However, there are cases in some individuals that basal cell carcinoma presents with pigment. And so it's important to see both basal cell carcinoma with pigment and without pigment. Right now, these first three images are going to show basal cell carcinoma with pigment, and then the next image is going to be basal cell carcinoma without pigment. But oftentimes you'll see telangiectasia within the cancerous growth. So we have these very fine blood vessels interlaced along the cancerous growth. We also see irregular pigmentation on the skin. So on the lower right hand side of the lesion, we have a heavy pigmentation, and then that pigmentation kind of fades out when you go to the left hand side. Another thing that you have to be mindful of is that you're going to see a bluish pink color within the lesion. So you kind of see this bluish pink on this section of the basal cell carcinoma, and it is irregular border. There is irregular pigmentation. You see telangiectasia along the lesion. And so those are kind of like red flags that you should be saying to yourself, hey, I see this on the patient, I should get somebody to confirm this, but this is basal cell carcinoma. And sometimes you'll see a heavy pigmentation on the center, and then these little flecks, these little spots of pigment kind of radiate outwards. And this is kind of like the spoke wheel presentation. So speckles of pigmentation radiating out from a heavily pigmented center. And it's you can miss it really, because you can just kind of quickly glance at it and move on. But if you see a collection of irregular spots of pigmentation, that is not melanoma, but rather it may be a basal cell carcinoma. So the difference between this one and melanoma is that melanoma looks like a stain on the skin, and that stain can be large or it could be small, but oftentimes it's going to be heavily pigmented. and not presenting like this. So when we look at melanoma, there's a complete contrast of how it presents compared to basal cell carcinoma. And again, these images are taken from DermNet New Zealand, which I am not affiliated with. And on this portion of this image, we also see some light pigmentation. We have some telangiectasia present within the lesion, and then it's kind of shiny and glossy. So sometimes you might present the basal cell carcinoma with flaking of the skin on top, and that is called superficial plaque whenever you have flaky skin on the top. These wounds or these lesions don't have any ulceration, but there are instances where the basal cell carcinoma does have ulceration, and if you see ulceration in any type of skin cancer, that means that the skin cancer is more aggressive and it needs to be treated with very delicately and immediately. So ulceration is always a bad sign. But for these examples, you don't see any ulcerations. These images show basal cell carcinoma that is non-pigmented, and you'll often see non-pigmented basal cell carcinoma more than pigmented basal cell carcinoma. And with non-pigmented basal cell carcinoma, you'll often see this blue pinkish color. You'll always see asymmetry for basal cell carcinoma. So what do I mean by that? What I mean by that is that this shape does not have nice symmetry. If you fold it in half, this portion, this left-hand portion, is not going to match with this right-hand portion. This upper portion is not going to match with this lower portion. That is asymmetry. We also notice that for this cancerous growth, we have some superficial plaque. We have some flaking of the skin. We also have ulceration here and here. There is a little bit of pigmentation on the bottom, but it's not readily apparent throughout the cancerous growth. There's also this nice blue pinkish color, and for the telangiectasia, it is not apparent. So sometimes you'll have telangiectasia, but in this case we don't really see that. It's not obvious. And because we have this ulceration, we can assume that this basal cell carcinoma is a bit more aggressive than usual. However, basal cell carcinoma has a lowered risk of metastasis. So it is very rare for basal cell carcinoma to metastasize to another part of the body. However, in this local region, it has the ability to spread and cause further damage. And sometimes, for basal cell carcinoma actually, we should know that for basal cell carcinoma, that occurs typically above lips. So above like your upper lip, you'll often see basal cell carcinoma, so it's often on the face, and because it has the ability to damage the skin, it often leaves a cosmetic disfigurement. And for individuals who have basal cell carcinoma, they have a lot of difficulty dealing with the surgical options. For instance, you might have basal cell carcinoma on the cheek or near the eye, and if you have surgical excision of the tumor, then it leaves a scar, and people feel self-conscious about that scar. So it's always nice to kind of have those discussions with the patient, because it does leave an impact on their lives. The face is very sensitive, and it's the first thing people see. So always have those talks about different treatment options and how it affects their lives in the long run. And while we are on the topic, while basal cell carcinoma typically is above the lips, when we talk about squamous cell carcinoma, that is squamous cell carcinoma, that is typically below the lips. So you often see that on the legs, behind the arms, behind the hand. You'll often see that on the chest. It is just an area below the lips. Can it occur above the lips? Yeah, it can. It can occur really anywhere on the body, but you often see that below the lips. For the next two images, we see telangiectasia, which is a defined collection of blood vessels. There's also kind of a raised area within the cancerous growth, and there is no pigmentation noted on this upper picture. However, we do see some pigmentation on this lower picture, and we see some heavy involvement of telangiectasia. There's also some crusting, and crusting usually means that there's an ulcer on the bottom. So whenever you have this ulcer, whenever it tries to heal, it will start to crust over. So if you see crusting right there, that means that previously there was an ulcer and that this cancerous growth is a bit more aggressive than usual. And to me, this would have been a very difficult area to examine because initially it looks like a bruise. However, what was suspicious is that there's a high density of these fine blood vessels and also some ulceration. So you can use ulcers and crusting and telangiectasia to kind of pinpoint an area that is suspicious. So again, these non-pigmented basal cell carcinomas are more typical than pigmented basal cell carcinoma. Basal cell carcinoma occurs because of UV radiation exposure, and basal cell carcinoma typically occurs above the lips, while squamous cell carcinoma occurs below the lips, for the most part. Throughout this video, we will be using histology slides produced by the University of Michigan Medical School, and I am not affiliated with the University of Michigan. They do not know that I am making this video, and this video is a non-profit medical education video to be used by medical students or individuals who are studying the skin. So we will be using these slides for educational purposes and not to diagnose anybody with cancer or any lesions. And you can use these slides as well. So all you have to do is just find whatever you want to type in, and then you can put Westscope and it's going to pull up a slide. So that's what we're going to be doing when we study cancer. Before we begin the histology portion of this lecture, I want to kind of show you normal histology of the skin. And this skin sample was taken from the scalp, and therefore you're going to have a lot of hair follicles protruding out of the skin. And now we're looking at the normal histology of the skin. We have this nice net looking presentation, and that is the stratum corneum. Under the stratum corneum, we're going to have this nice layer, and that is called the stratum granulosum. Under the stratum granulosum, we have the stratum spinosum, and then if we go a little bit further down, we're going to have the stratum basale, and that has the basal cells. And the basal cells are very nice. They look very pretty. And that's just normal skin histology. Notice that we have the dermis, and the dermis is pink. It has pink collagen, and it's going to be protruding into the epidermis with these little fingers. So these pink fingers are called dermopapillae, and they typically go into the epidermis. And the reason why we have dermopapillae is that they form connections with the epidermis, and that promotes strong connections between the epidermis and the dermis. Whenever you have these strong connections, it's very difficult for the epidermis to be rubbed off, and that protects us from having any trauma. So you will always see these dermopapillae within normal skin. And we can say that the purple fingers that go into the dermis, those are called rete ridges. Rete ridges, R-E-T-E, rete ridges. You might hear some people call them rete ridges. But yes, notice how the cells are kind of uniformly organized, and they appear to be like the same size right here. So they have the same size, they're uniformly organized inside the epidermis. There is no clustering of the cells. Also, when we talk about hair follicles, you don't have to be worried about hair follicles that look like this, because this is a normal presentation of the hair follicle. It looks like a stratum basale right here inside this hair follicle, and that's because it is. These are basal cells, and when basal cells start replicating, they make keratinocytes, and keratinocytes will die and produce the hair, because the hair is just made of dead keratinocytes, and the hair is made from that protein called keratin. So keratinocytes produce keratin, and they make up this nice hair follicle. So this is what normal hair follicles look like. And in certain types of cancer, you will have some clustering of the cells within the hair follicles. And of course, that is not good. So this is what normal hair follicle presentation looks like. And it's going to extend outwards into the outside world. And right next to the hair follicles are these nice sebaceous glands, which produce sebum, and sebum is an oil that is going to be placed onto the hair follicle using the holocrine secretion method. And this is basal cell carcinoma, and we can see that there is a clustering of these keratinocytes. So this is completely different from what you see with normal presenting skin. Everything looks organized. The cells have a uniform size. The nucleus has a nice uniform size compared to the cytoplasm. Here's a nucleus and the surrounding cytoplasm, but that is absent in this presentation. So as you can see here, the nucleus are a bit larger than the cytoplasm, and that's very typical for skin cancers. The ratio of nucleus to cytoplasm is a lot larger, so you often have these large nuclei with very small cytoplasms next to it. We also have a very large compaction of these keratinocytes within the stratum basale. So the stratum basale has an abnormality due to being exposed to a chronic period of UV radiation. So now you have DNA damage of the keratinocytes. You have an underexpression of p53, and you also have a mutation within the CDKN2A tumor suppressor gene. Now notice that you have so many keratinocytes, and they start kind of pushing on each other. To me, it looks like you're on a train with a lot of people, and the more and more people that are on this train, the more compact you become. You become squished, you become elongated. You can see right here, this guy is pushing on this guy, and this guy is pushing on this guy, so they have a narrow appearance. You also have an enlargement of this nuclei, and because you're pushed so compactly, you form kind of like a fence, like a little fence right here, and you can actually see it right here. It's very nice. It looks like a picket fence, and it goes right there. Here's a jelly bean, like that. And what this is called is actually the palisading effect. So for basal cell carcinoma, and you also see this for squamous cell carcinoma, you have this nice fence formation, and that is called the palisading effect. So if you see palisading effect, that should be a red flag that you're looking at cancer. And you don't see this nice formation of a fence in normal skin histology. You can actually see that the nuclei are round and they're short and stubby, but the nuclei here are elongated and they look like little cigars. That's because they're compact and they form this palisading effect. For dermatologists like to use a word called atypical presentation. Atypical presentation just means that it is not typical for the cell to look this way. This is atypical presentation, and this is typical presentation. Atypical, typical. A form of atypical presentation is called pleomorphism, and pleomorphism means that the cells do not look similar to each other. What do I mean by that? Well, this cell right here looks a lot different than this cell, and this cell looks a lot different from this cell, and this cell looks a lot different from this cell. So that is a form of pleomorphism. So we have some pleomorphism presenting inside the basal cell carcinoma. We have a palisading effect, and this is an atypical presentation of the skin. Whenever you have a large concentration of keratinocytes, like we see palisading and then just have like a jumbled mess of basal cells, we have the weakening of the collagen around it. So here we can see the weakening of the collagen, and we have some tearing of the sample. Also, we can see a nice little gel formation on the basement membrane of this island. But what is this? What you see here, and it's very difficult to kind of make out here, but that is mucin, and mucin is a product of the keratinocytes. So it's actually kind of like an artifact when you're staining the sample. So whenever you get a skin sample and you prepare it and you stain it and then you put it on a slide, you often see these nice rings of mucin around the tumor, and that is a hallmark of basal cell carcinoma. So the hallmark of basal cell carcinoma is this mucin ring. You also have the palisading effect, and for certain types of stains, like this is an H&E stain, you'll see it's kind of bluish. This is not really a good example of that blue color, but it's something that you often see. So we have this nice palisading effect, we have this tearing, we have kind of like a ring formation around of mucin, and that is basal cell carcinoma. And it's actually on the surface of the, well, of the dermis. So it's superficial basal cell carcinoma, so it's not invading the dermis. And you're probably wondering, well, Brian, I see all these specks of black dots. Isn't that keratinocytes? Isn't it invading the dermis? And really, it's not. These are actually immune cells. These are lymphocytes. So whenever you have the formation of cancer inside the skin, and you often see this with melanoma, squamous cell carcinoma, basal cell carcinoma, you're going to have an increased concentration of those lymphocytes because the body doesn't like it when it has a lot of inflammation. So what I'm saying here is that when you have skin cancer formation, you're also going to have inflammation and irritation at the offending site. And whenever you have inflammation, the body gets irritated and it starts sending out these lymphocytes. So oftentimes you're going to have an increased concentration of those lymphocytes at the cancer areas. And you can see here, this is normal skin. You don't really see a high concentration of these lymphocytes. Like, you have lymphocytes, these are normal. They're just always going to be on the skin, obviously, because bacteria like to kind of try to sneak inside the skin. So you need these lymphocytes to defeat the bacteria. But you don't see a high concentration in one area. This is a lot different. You can see a large concentration of these lymphocytes towards the edge of the epidermis. And I'll show you more examples of an increased concentration of lymphocytes when I see them. But this is superficial basal cell carcinoma, and this is what it looks like. Previously, we were looking at the superficial basal cell carcinoma. However, now we're looking at invasive basal cell carcinoma, and this is a more aggressive form of basal cell carcinoma. Right here, we notice that this stratum corneum is a bit thicker, and it also has nuclei inside of it. This is a lot different from normal skin presentation. So we have some nuclei inside the stratum corneum. Normally, you wouldn't have those nuclei inside the stratum corneum, but here we have the nuclei. And whenever you have nuclei inside the stratum corneum, that is called parakeratosis. And parakeratosis occurs because the basal cells are developing so quickly that they rush into the stratum corneum, and they rush so quickly that they don't have time to lose this nuclei. So you often see parakeratosis within psoriasis, squamous cell carcinoma, and also basal cell carcinoma. And in normal histology, the stratum granulosum is responsible for the nuclei leaving the keratinocytes. That's a normal presentation. However, it's very difficult to see the stratum granulosum here. And in fact, I would argue that there is no stratum granulosum in this area. And because you have no stratum granulosum, you have the ability to retain those nuclei inside the keratinocytes. And that is severely abnormal. So you can see a lot of nuclei kind of right here inside the stratum corneum. And again, that is called parakeratosis. And that is because the keratinocytes are rushing into the stratum corneum because they are developing so quickly inside the stratum basale. And you're probably wondering, okay, but what is this gray, gooey mess that I see here? Well, along the islands, well, not really islands, but along the fingers of this invasive basal cell carcinoma, you'll often see this gray matter, this gray goop. And what this is actually toughened collagen. So in normal histology, we have this nice pink collagen, and it's very healthy, it's very pretty, but then you have solar elastosis. And solar elastosis is just when the UV rays have penetrated the skin for so many years, and it starts irritating, it starts damaging the collagen, and the collagen doesn't like that, and so it starts to toughen up, it starts to get tougher and stronger, but when it does it, it picks up a different color. So this is solar elastosis, and it's just really the replacement of soft collagen with very tough and firm collagen. And again, that is solar elastosis. And you typically see solar elastosis with basal cell carcinoma, actinic keratosis, and squamous cell carcinoma. And that just means that it is a very chronic exposure to UV radiation and skin damage. Typically, whenever you have invasive basal cell carcinoma, you're going to have these finger-like projections going into the dermis, and this is actually a very exaggerated invasion into the dermis. We can see these finger-like projections, and sometimes it's very difficult to see the palisading effect of basal cell carcinoma inside the finger-like projections. Like, you don't really see the palisading effect here, but you do see a clustering of these keratinocytes right there. And we have some pleomorphism right there. This cell, for instance, has a very large nucleus compared to this guy right there. And I want to kind of show you the high concentration of lymphocytes and kind of show you the difference between lymphocytes and keratinocytes so that you're not confused. These are lymphocytes. You can see that they're a lot smaller, and they don't have an exaggerated cytoplasm next to it. Here are the keratinocytes, and right next to them are these little black freckles. To me, they look like poppy seeds off of a poppy seed bagel, which are my favorite bagels, by the way. So if you want to give me a bagel, you can give me a poppy seed bagel. But this is a lymphocyte. And again, we have inflammation and irritation within this tumor. And because you have inflammation and irritation, you have a high concentration of these lymphocytes. So normally these lymphocytes are going to be kind of nibbling on the cancerous keratinocytes, and they're going to try to get rid of these keratinocytes. So of the lymphocytes, we have like dendritic cells, we have monocytes, macrophages, all those great immune cells trying to attack the tumor. However, this is actually overwhelming. So you have an overwhelming invasion. And here you can see more lymphocytes right there, the black dots, and they're trying to attack these keratinocytes. Again, we have basal cell carcinoma, but this one is a little bit different. We can see kind of like the clustering of the basal cells right here, and they form this nice palisading effect, this nice fence structure. We have the stratum corneum, and it looks to be absent. Sometimes the stratum corneum is rubbed off when the slide is prepared, but sometimes you have a little bit of remnant of the stratum corneum. Anyways, so you have the stratum granulosum, the stratum spinosum, and then you have the abnormal stratum basale. But what makes this slide a little bit different is because this is nodular. This is nodular basal cell carcinoma, and nodular basal cell carcinoma is a lot more aggressive than just superficial basal cell carcinoma. And what you see here is these little islands of basal cell carcinoma. And I wanted to show you the nodular form because this slide has that blue color. So whenever you stain basal cell carcinoma with H&E staining, you get this nice brilliant color, and to me it's absolutely beautiful. Like I love this color. But you want to see this nice ring of pink, and this highlights what you're looking at. You're looking at the mucin ring around the basal cell carcinoma. You also have this gap, and this gap is called the cleft, and a cleft is just an artifact of preparing the slide. So whenever you prepare the slide for histology, sometimes you're going to have kind of like some shrinkage of the cytoplasm, and that is going to be kind of releasing this mucin ring, and it also kind of clings to this nucleus. So whenever it clings to the nucleus, we have this gap, and this is called the clefting artifact. It is very prominent for basal cell carcinoma. And then you also have this nice mucin ring, which is just a byproduct of the keratinocytes. And we have these nice nodes, these nodular presentation of the basal cell carcinoma. And we have some finger-like projections, and this is an invasive form of basal cell carcinoma, so it's a lot more aggressive. We have a lot of these islands, and that is basal cell carcinoma, and it is nodular. And like I said, I'm just a medical student. I'm not a professional at looking at histology. I'm not a pathologist. I'm not a dermatopathologist. So if you notice something inside the slide and you say, hey, you didn't mention this, or you overlooked this presentation and that's critical, well, I'm only highlighting kind of like the essentials of what you should know for basal cell carcinoma. If you want an in-depth presentation of skin cancer and pathology for the skin, I highly recommend looking at the YouTube channel Gardner. He is a licensed medical professional, and he does dermatopathology. So he actually looks at skin slides, and he actually breaks it down pretty nicely. So I highly recommend watching him if you're studying for boards, or if you just want a more in-depth look at the pathology of skin cancer. So again, I'm not a professional at this, I'm just kind of highlighting the essentials. Now that we've seen the histology of basal cell carcinoma, we have to talk about the treatment for basal cell carcinoma. One of the best treatment options would have to be surgical incision of the tumor. However, let's say that you have basal cell carcinoma on a patient and it is on the eyelid. So it's going to be very difficult for surgical incision to happen on the eyelid. So that's when we start using topical medication. So one of the most known topical medication for basal cell carcinoma is called fluorouracil, and we're going to be talking about the 5% concentration of that medication. So the end goal of fluorouracil is to block the DNA from repairing itself inside cancerous tumors. So whenever we use 5-fluorouracil, what is going to happen is that it enters the skin and it becomes fluorodeoxyuridine. So 5-fluorouracil is going to convert itself, and we see here 5-fluorouracil is going to convert itself into fluorodeoxyuridine monophosphate. That is fluorodeoxyuridine monophosphate. And what happens with fluorodeoxyuridine monophosphate is that it's going to combine with something called thymidylate synthase, TS synthase. And whenever it combines with thymidylate synthase, it's going to block the creation of deoxythymidine monophosphate. But why do we care about deoxythymidine monophosphate? Why do we want to block it? Well, we want to block it because this guy is going to be used to repair DNA. For cancer, we have this really bad DNA, and this DNA has abnormalities. And right here we have the little ladder of DNA. I'm not an artist, obviously, so I can't really draw, but that's going to be the DNA. And we have some abnormalities right here inside this cancerous cell. So for whatever reason, the UV radiation has mutated this DNA, and now we have the proliferation of skin cells, and that's what you saw for the histology of basal cell carcinoma. So it arises from a damaging of the DNA. And what happens here is that as the DNA continues to function, eventually it's going to start breaking down, and this cancerous DNA wants to repair itself. So it's going to be using deoxythymidine monophosphate to repair itself. And if it repairs itself, the proliferation of cancerous cells will continue. The body will continue to create those cancerous cells. However, if we can block the mutated DNA from repairing itself, eventually those cancerous cells can no longer replicate and they start dying off. And eventually you start decreasing the cancerous cells and you start repairing the body with normal cells. So to recap, we're going to use 5-fluorouracil to block the cancerous DNA from repairing itself. If the cancerous DNA can no longer repair itself, eventually the cancerous cells begin to die and they are replaced by normal, healthy cells. Again, to recap, 5-fluorouracil is going to convert itself into the body by forming fluorodeoxyuridine monophosphate. Fluorodeoxyuridine monophosphate is going to combine with thymidylate synthase, and when fluorodeoxyuridine monophosphate combines with thymidylate synthase, is going to block the formation of deoxythymidine monophosphate. And when you block deoxythymidine monophosphate, the DNA of the cancerous cells can no longer rebuild itself, it can no longer repair itself, and therefore you have a decreased concentration of cancerous cells over time. So that is why we care about deoxythymidine monophosphate. Let's say that there is no cancer in the body and that this is a normal, healthy body. So I want to kind of talk about this process right here. So what we're using is called folate, and that is vitamin B9. Vitamin B9 is going to communicate, it's actually going to attach itself to thymidylate synthase. In addition to this, we also have deoxyuridine monophosphate. So the combination of deoxyuridine monophosphate and vitamin B9 attaching itself to thymidylate synthase, that is going to create deoxythymidine monophosphate. And the healthy DNA is going to be using that to repair itself. And that is seen in a healthy body. That is why we need folate inside our diet. We also need vitamin B12. And vitamin B12 is also found inside our diet. So we need vitamin B12 and vitamin B9 to help repair and to create DNA. But in this example, we're just using folate, vitamin B9. And that kind of shows the importance of blocking deoxythymidine monophosphate whenever you have cancerous cells replicating that DNA. So you only use fluorouracil if you have cancerous cells that are trying to repair their DNA. And you're probably saying, hey, wait a minute. If I'm blocking the DNA from repairing itself, wouldn't the DNA of healthy skin cells also be affected? You know, that is a good question, and it's a good observation. However, with fluorouracil, we're just going to kind of abbreviate it to FU, and you often see it as 5FU. 5FU has a high preference for cancerous cells. So let's say that we have a cancerous cell right there and it's going to be pink, and then we have a normal skin cell right there. And then we're going to put some 5-fluorouracil on top of it. It's a cream. Well, here we're going to have some absorption of the 5-fluorouracil inside the cell, but not as much. However, for the cancerous skin cells, for whatever reason, we have a high absorption rate of 5-fluorouracil inside the cancerous cell. So now this DNA of the cancer cell can no longer repair itself. So it has a high preference for cancerous cells, and it has a slight absorption rate for the healthy skin cells. So therefore, the usage of 5-fluorouracil is not going to damage the healthy skin cells as much. Yeah, there is some loss of DNA repair for normal skin cells, but not to the same level as cancerous skin cells. And I also want to mention something in that 5-fluorouracil is a pyrimidine analog. And I don't really care if I spelled analog incorrectly. It doesn't matter. What it means is that 5-fluorouracil has a very, very similar structure to uracil and thymine. Uracil is seen in RNA, and then thymine is seen in DNA. And again, we're going to have kind of our swirly DNA right there. And then we have the little ladders of pyrimidines. So let's say that this right here is a thymine right there. What 5-fluorouracil, we're just going to call that FU. 5-fluorouracil looks so much like thymine in that it will replace thymine and it's going to go inside the DNA. So now we have 5-fluorouracil sneaking inside of the DNA and replacing thymine. And when this happens, DNA cannot replicate successfully. It has kind of a damage to it. So we have this pyrimidine analog. 5-fluorouracil looks so much like thymine that it's going to replace thymine inside the DNA, and is going to kind of cause the DNA to not be able to replicate. So that is a pyrimidine analog. If we were talking about RNA, instead of thymine, we're going to be replacing uracil. So uracil is going to be kicked off, and 5-fluorouracil is going to take its place, and that prevents the RNA from further replicating, and it promotes RNA or DNA damage. So again, when you're studying for USMLE, like step 1, you're going to have to know the mechanism of action for 5-fluorouracil, and you're also going to have to know that it is a pyrimidine analog. So keep that in mind. Let's talk about the contraindication for 5-fluorouracil. When do you not give 5-fluorouracil to an individual? Well, you don't give 5-fluorouracil to a person who has an allergic reaction. You also don't give it to an individual who has a deficiency in dihydropyrimidine dehydrogenase. That is a contraindication. Normally, dihydropyrimidine dehydrogenase is the enzyme that will metabolize about 80% of the 5-fluorouracil whenever you use the medication. So normally you want the medication to do its job and then leave the body. Dihydropyrimidine dehydrogenase metabolizes the medication and excretes it from the body. If you have a deficiency in dihydropyrimidine dehydrogenase, you do not give that medication, because without this enzyme, you have the concentration of fluorodeoxyuridine increasing. And when you have an increased concentration in this medication, it leads to toxicity. So you don't want to have a toxic amount of medication in your body. So prior to giving 5-fluorouracil to an individual, you would have to kind of do a test to see if they have a normal amount of dihydropyrimidine dehydrogenase. If they do not have a normal amount of dihydropyrimidine dehydrogenase, you would have to look at a different medication. So you don't want to be giving 5-fluorouracil to an individual that is deficient in dihydropyrimidine dehydrogenase. Some side effects of 5-fluorouracil include erythema. So erythema is the reddening of the skin. You might have some ulcer formation and also some eczema, so some irritation of the skin. But the main thing you have to look out for is if the patient is deficient in dihydropyrimidine dehydrogenase. Moving on, we're going to be talking about actinic keratosis. Actinic keratosis. And that is one of the most common skin conditions that a dermatologist looks at. So about 1 in 7 people who consult with a dermatologist are going to be consulting about actinic keratosis. And again, you have this formation of this skin condition because there is a chronic exposure to UV radiation. Now, actinic keratosis actually is not, so this is actually not skin cancer. Actually, it is pre-cancerous. And about 8 to about 16% of actinic keratosis, AK, develop into squamous cell carcinoma. So actinic keratosis is not cancer. However, if left untreated, it has an 8 to 16% chance of developing into squamous, however you want to pronounce it, cell carcinoma. And really, it's above 5% significance. So if anything is above 5% significance, you want to treat it. You don't want to just let it sit on the skin and have the risk of developing into malignant cancer. So whenever you're looking at a patient, and we'll see how this presents on the skin, whenever you're talking to a patient and they have actinic keratosis, you should refer them to a dermatologist, or you should get a dermatologist to look at that skin, because 8 to 16% chance is significant, and you don't want to develop squamous cell carcinoma or squamous. What happens during actinic keratosis development? Well, again, it arises because there is chronic exposure to UV radiation. UVA is going to enter the skin and is going to create reactive oxygen species, and these reactive oxygen species are going to start damaging the DNA. For UVB radiation, it will directly enter the cells and it's going to directly damage the DNA. That is a very important difference between UVA and UVB. Here we have the damaged keratinocytes, and when you have damaged keratinocytes, you have a damaging of the p53 tumor suppressor gene, and p53 is going to induce cell apoptosis. That means cell explosion, and you want apoptosis normally because you don't want cells to continue to develop and proliferate. You want a normal amount of cells. If you have a decrease in p53 expression, you have an abundance of cells. You have too much cell development, and that causes crowding. Over time, as the actinic keratosis progresses, you have the thickening of the stratum corneum, and that is because you have too much keratinocytes building up inside the epidermis. So typically you're going to see a very large thickening of the stratum corneum. So you have a thickened stratum corneum. And over time, if you allow the actinic keratosis to persist, it has the possibility of developing into squamous cell carcinoma, and we don't want that. So actinic keratosis increases the inflammation of the skin, the immunosuppression of the skin, and it increases the development of keratinocyte inside the epidermis. Here are some Dermoscope images of actinic keratosis, and what we should be looking at is kind of like a strawberry pattern inside the skin. So these two images, this top image and this image right here, this is actinic keratosis of the face. And what I want to point out is that for the most part, actinic keratosis is going to have a lot of flaking on the surface. You have a hardening of the keratinocytes, and it looks a lot like squamous cell carcinoma. But for these examples, I wanted something that was more distinctive so you won't confuse yourself with squamous cell carcinoma. So really, actinic keratosis has this strawberry pattern on the surface, and you also have a halo of white pigmentation of the skin. So here we have a halo of whiteness. We also have a halo of whiteness right here, and another halo. We also have telangiectasia, which are these fine vessels interlaced around the area of interest. Here we have some hardening of the keratinocytes a little bit. It's very faint, you can barely see it, but it is some hardening of the skin. We also have just little blobs of whiteness sometimes. So you have a blob of whiteness here and also here. And on this picture, this is an area where it is on the body, it's not on the face. So this is a non-facial actinic keratosis. And you also have some superficial plaque right there. You have some flaking of the skin, a little blob of whiteness here, some whiteness interlaced around the area of interest. But what is important is that sometimes you're going to have some partial pigmentation of the area. So for this individual, this individual was white. This is a fair-skinned individual, but around the area you have some pigmentation. So it's kind of like infrequent pigmentation around the area, some flaking of the skin, some redness, and it's not raised for these examples. However, clinically it is very difficult to kind of tell the difference between squamous cell carcinoma and actinic keratosis. So it is always best to kind of do a biopsy of the area. So you would have a little section of skin and you would send that to pathology. And pathology would be able to kind of tell the difference between actinic keratosis and squamous cell carcinoma. But even then, it is very difficult. So one of the most important things you have to remember is that when you see these presentations, it's always best to consult with dermatology and to kind of treat the area. You don't want this to sit on the skin for too long because, again, it has that chance of developing into squamous cell carcinoma. And squamous cell carcinoma has the ability to metastasize and to be fatal for the patient. So don't just say, hey, it's just actinic keratosis, we're going to leave it alone. No, you're going to have to treat it. Another name for actinic keratosis is solar keratosis. Because again, sometimes you're going to have some flaking of the skin, you're going to have some hardening of the skin, and it looks like squamous cell carcinoma. So just be careful with it and treat it seriously. Also, before I move on, I just want to mention that the rate of actinic keratosis increases as you kind of go near the equator of the Earth. So in different countries that are closer to the equator, for instance, Australia, they have a high density population of fair-skinned individuals. These are individuals who are lighter skinned, and they are exposed to high amount of sunlight and UV radiation. And so in New Zealand and Australia, so for instance, this is DermNet New Zealand, they have a high population of individuals who have actinic keratosis, and that is because they have a less amount of melanin in their skin to protect them from UV radiation, and they are also exposed to high levels of UV radiation in the summertime. So over periods of years and years and years of living, you have kind of like this toughening of actinic keratosis on the skin. So now that we've discussed the dermoscope images of actinic keratosis, let's kind of do a pathology of it. Let's look at the histology of actinic keratosis. I wanted to show you a slide of exaggerated actinic keratosis so that it's a bit more obvious for you, because normally you don't have actinic keratosis that is this distinct. So this is actually called hypertrophic actinic keratosis, and we can see obviously that there is a thickening of the stratum corneum, and that is completely different from just kind of normal skin histology. So this is normal skin histology, and we can see that the stratum corneum is not as exaggerated as it is in here. Also notice that we have the dermopapillae, and we have the rete ridges right there. But also notice that we have inflammation. We have inflammation, and we can tell that we are inflamed because we have a high concentration of those lymphocytes. They look like little poppy seed freckles. So we have the lymphocytes being irritated, and they're trying to go into the site of irritation. So here we have some freshness right there. This is irritation of the skin. It's red. And if we look further down, we can see that in this portion of the stratum corneum we have perikeratosis. So again, we're going to have some inflammation occurring at the bottom near the stratum basale, and then we have the overproliferation of the keratinocytes. So they rush into the stratum corneum and cause perikeratosis, in which you still have some nucleus or some nuclei inside the stratum corneum. Right there. It's very distinct. And we have kind of a thickening of the stratum granulosum. I also want to mention that there is no palisading effect of the actinic keratosis. So there is no palisading effect. You don't see a nice picket fence as you do in basal cell carcinoma. You just see kind of some atypical presentation. For instance, you might have some thickening of the keratinocytes within the stratum spinosum going onwards into the stratum corneum. But for sure, this is a hypertrophic actinic keratosis, and it's just a thickening of the corneum. Actinic keratosis is not going to invade the dermis portion. So if you see any thickening of the corneum and you're suspecting actinic keratosis, but then you notice that one of these fingers kind of invade deeply into the dermis, most likely you're not dealing with actinic keratosis. So here we have more actinic keratosis. You kind of have some projection into the lower part of the skin, but it's not that exaggerated. So it's really an abnormality within the stratum basale and the stratum spinosum, and that is due to an overexposure of UV radiation. And typically, whenever you have actinic keratosis, you're also going to have solar elastosis. And that's what you see here. That's the gray collagen, and that's just a collagen being toughened because of chronic exposure to UV radiation. So that is solar elastosis. And here's one more example of actinic keratosis. We have the exaggeration of the stratum corneum. But I wanted to point out that you don't always have to have nuclei inside the stratum corneum. Like right here, you don't really see that many nuclei inside the stratum corneum. At least it's not overly apparent. So perikeratosis doesn't have to be present for actinic keratosis. You still have your rete ridges and your dermopapillae. However, you have the abundance of the epidermis. Also, you have this nice example of the stratum lucidum. So this was probably taken around the skin of thick skin, so maybe on the arm or on the sole of the foot. But you also have the possibility that this person was picking at the skin for so long, like they have like this flaking of the skin, so they keep picking at it and picking, and they eventually form thick skin. So the skin has been picked at for so long that the skin has thickened up, and it causes the formation of the stratum lucidum. So that can also be a possibility. But that's a nice example. And stratum lucidum typically has a protein called elidine, and elidine is typically created from the keratohyalin that is formed from the stratum granulosum. So that's just a bit of dermatology for you. So yeah, notice that we're not invading the dermis layer. So we're not invading the papillary dermis or the reticular dermis. So it's just kind of superficial to the epidermis, and we have this exaggeration of the stratum corneum. One of the treatments for actinic keratosis, and really basal cell carcinoma, and you'll later find out squamous cell carcinoma, is that we can use something called imiquimod cream. And what that does is that it's going to act as an immunomodulator. But what does imiquimod do? What does it do? Well, imiquimod is going to increase the immune response. But how does that do that? Well, it's actually going to kind of interact with toll-like receptor number 7 and number 8. But what is a toll-like receptor? Your immune cells, let's say that this is a little dendritic cell, and the dendritic cell is going to have little arms and stuff like that. So here are the little arms, and if we zoom in, we have these little toll-like receptors. Normally we have some cancer cells right here. However, the immune response is not effectively taking out those cancer cells, and it uses these toll-like receptors to kind of recognize if there's a cancer cell here. So what imiquimod does is that it's going to activate, or it's going to further activate these toll-like receptors. And there are two of them, toll-like receptor number 7 and toll-like receptor number 8. Imiquimod is going to increase the activation of the toll-like receptors. And if we increase the activation of toll-like receptors, we increase the immune response so that we can kind of gobble up these cancer cells. So imiquimod increases the immune system's ability to get rid of those cancer cells. And that's really all you have to know. You don't have to overcomplicate it. You just have to know that imiquimod is used as an immunomodulator. So when would you kind of consider imiquimod? Imiquimod doesn't really have any contraindications. However, if you notice that the patient is allergic to imiquimod, obviously you wouldn't use imiquimod. You can consider imiquimod. Let's say if the patient had a deficiency in dihydropyrimidine dehydrogenase. So for instance, this patient has basal cell carcinoma. We want to prescribe 5-fluorouracil, but we realize that this person has a deficiency in D-pyrimidine dehydrogenase. Therefore, we can't use 5-fluorouracil, so we would then consider imiquimod cream. Now, a downside to imiquimod cream is that it can increase the risk of having scarring after the cancer has been treated. So if you're treating basal cell carcinoma, you can put imiquimod cream on it, and then over time it may heal completely, but it also has the risk of forming scars. So that's kind of a downside, especially if you're treating something on the eyelid. Again, I'm not trying to prescribe imiquimod cream to anybody who has skin cancer, or I'm not telling you to switch different medications. I'm just kind of giving a rundown of different treatment options for medical students to learn about. And that is the mechanism of action. We're going to be increasing the toll-like receptor number 7 and number 8 efficiency to kind of recognize those cancer cells and to gobble them up and to get rid of them in the skin. And again, imiquimod cream can be used for basal cell carcinoma, actinic keratosis, and superficial squamous cell carcinoma. If we look back to superficial basal cell carcinoma, we can see that there is a high exaggerated concentration of those lymphocytes. And again, lymphocytes are just the immune response to this inflammation and irritation that is prominent within the tumor area. So here we have these lymphocytes, and of these lymphocytes you have the monocytes, macrophages, dendritic cells. And if we use imiquimod on the area, this increases the lymphocytes' ability to kind of get rid of these cancerous cells. So you can barely see the keratinocytes are right here, and you kind of see like the little projections. The lymphocytes are trying their hardest to kind of get rid of these cancer cells as they build up on the epidermis. So if a person uses imiquimod, you increase the activation of the toll-like receptor number 7 and number 8 on the lymphocytes, and that increases the immune response to the cancerous cells. So that helps to kind of defeat the cancerous development. So that's really effective whenever you have superficial cancer. For instance, superficial basal cell carcinoma or superficial squamous cell carcinoma. Whenever a dermatologist says something is superficial, they often say basal cell carcinoma in situ. So IN, so inside of something, and then situ. Situ just means site, so in sight. That just means that it is really confined to the epidermis layer, the epidermal layer. So this is a basal cell carcinoma in situ, and we have an exaggerated immune response. And if a person uses imiquimod, then they would actually get rid of this cancerous development over time, because you're increasing the immune response to the cancerous development. I want to mention a treatment option that is really specific towards actinic keratosis. You don't want to use this medication for basal cell carcinoma or squamous cell carcinoma. It's really effective for actinic keratosis. So that is the precancerous formation before squamous cell carcinoma. And what I'm talking about is prescription name is called Solarase gel, but the generic name is actually called diclofenac sodium, and it's not just normal diclofenac sodium. If it was just normal diclofenac sodium, it would be called Voltaren, and that is a V, Voltaren. And you can find this at your local drugstore, just over-the-counter Voltaren. But this is different because, first of all, it's 3%, this is only 1%. And then they combine the diclofenac sodium with something called hyaluronic acid. And the hyaluronic acid is a 2.5% concentration. So here in the inactive ingredient, the first ingredient has to be hyaluronate sodium. So the combination of diclofenac sodium and hyaluronic sodium creates a very nice medication that can be used for actinic keratosis. And the mechanism of action is that diclofenac sodium is actually called a non-steroidal anti-inflammatory drug. So it's an NSAID. And we care about the inflammation because when actinic keratosis develops, as we saw in the previous diagram, the inflammation increases and we have an immune response. If we can get rid of this inflammation, we can kind of decrease the actinic keratosis formation, and we can actually reverse it over time. But this usually takes about 3 to 6 months of application. So you can apply it for about twice a day to the affected area. And what happens here is that NSAIDs are going to kind of block the formation of two enzymes. There's something called the cyclooxygenase number 1 enzyme, and there's something called the cyclooxygenase number 2 enzyme. And there's actually a spectrum. There's a spectrum in which the medications are going to have an effect. So there's a little line right here. So for instance, if you use something called Toradol or ketorolac, ketorolac is an NSAID, but that has a preference for the blocking of this enzyme. And you have something called Celebrex that is has a higher preference for the blocking of this other enzyme. And between the spectrum, you have the normal NSAIDs, like for instance ibuprofen, you have Motrin, just to name two of them. And then right here on this kind of leaning towards the cyclooxygenase number 2 inhibition, we have diclofenac, and we're just going to call that DF. So that looks like a P. So we have diclofenac right there. So it leans more towards the inhibition of cyclooxygenase number 2. But why am I mentioning cyclooxygenase enzymes? Well, I mentioned cyclooxygenase enzymes because we are producing something called prostaglandins. Prostaglandins. What is a prostaglandin? Well, a prostaglandin is kind of like the mailman of the body. Whenever two cells are next to each other, let's say that this cell is becoming irritated. It's getting there's some cell division that's happening, let's say actinic keratosis, and we have some damaging to the cell. Well, the cell doesn't like it. So now it's going to start producing prostaglandins. And these prostaglandins are going to send a signal, a message to another cell. And now this cell is going to get that message, and now it's going to start creating more prostaglandins, and they signal for the inflammation of the area. And hopefully this inflammation increases the temperature and gets rid of those cells or any type of bacteria. So that causes inflammation in general. And it's due to these prostaglandins. And prostaglandin is made by the cyclooxygenase enzymes. So if we can block those cyclooxygenase enzymes, we can decrease the prostaglandin formation and therefore decrease the inflammation in the body. But why do we care about cyclooxygenase number 2 in terms of actinic keratosis? Well, normally cyclooxygenase number 1 is found in normal concentrations in the body. Cyclooxygenase number 2, it is produced, however, it is in a reduced amount. When we deal with actinic keratosis, the amount of cyclooxygenase number 2 enzyme increases dramatically. So we have an increased concentration of cyclooxygenase number 2 enzyme when we're dealing with actinic keratosis. And when we have an increased amount of cyclooxygenase number 2, we have an increased amount of the prostaglandin PGE2. So that is prostaglandin E2. Now here's where it gets a little confusing. Cyclooxygenase number 1 also produces PGE2. So there is a normal concentration of PGE2 inside the body. Let's kind of make a random level. Let's have this nice level right here. Let's call it 5. So normally we have, let's say 5 prostaglandin E2s activated at any given moment. But because we have the activation of cyclooxygenase 2 due to actinic keratosis activity, now we have an increased concentration of PGE2. So PGE2, instead of being 5, let's say it's 30, just to make up a random number. So normally cyclooxygenase number 1 creates PGE2, and that's fine. You don't really see cyclooxygenase number 2 being produced inside the body. However, during actinic keratosis, you have an increased inflammatory response, and therefore you have an increased production of cyclooxygenase number 2. And because you have an increased production of cyclooxygenase number 2, you have an increased production of prostaglandin E2. And that increases the concentration of prostaglandin E2 from 5, and we change it to 30. And we care about this because the overproduction of prostaglandin E2 increases the risk of tumor genesis, or the generation of tumors. So when do we have an increased production of cyclooxygenase number 2? We have an increased production of cyclooxygenase number 2 when we have UV exposure. So cyclooxygenase number 2 is not normally found elevated in the body unless there is UV radiation exposure over a long period of time. Therefore, the cyclooxygenase number 2 concentration increases, and with it, the concentration of prostaglandin E2 increases as well. And if you have excessive amounts of prostaglandin E2, you're going to have an increased risk of forming tumors, in this case actinic keratosis, which can then lead into squamous cell carcinoma. And I mentioned this, and I spent so much time on it because it's always going to be present in the USMLE and also in STEP. So whenever you're studying medicine and you're studying for your exams, that's always going to be kind of like a question, you know, why this occurs and what kind of medication we can give or how it presents. So you have to realize that this is what happens. And so if we use topical 3% diclofenac sodium in combination with 2% or 2.5% hyaluronic acid, we can block this cyclooxygenase number 2 enzyme, and we can decrease the amount of prostaglandin E2 creation. And if we decrease the concentration of prostaglandin E2, we decrease the ability for the tumor to grow or to develop. And we use hyaluronic acid so that we can heal the skin even further. So I wouldn't recommend just using pure diclofenac sodium 3%. That's not going to have a greater it's not going to be that effective. Studies have shown that diclofenac sodium in combination with hyaluronic acid 2.5% is more efficient and has a better success rate than just using a mono treatment of diclofenac sodium. And you're probably wondering, well, why are we just using topical medication? Why are we using diclofenac sodium with hyaluronic acid instead of Celebrex? Because I noticed that Celebrex has a high preference for cyclooxygenase number 2. Why don't we just use Celebrex instead? Well, Celebrex is given in a capsule form, and the condition that we're dealing with is on the topical. It's on the skin. So we want to get to the source, we're going to put it directly on the skin. Also, Celebrex, it is not more efficient than the topical route. There's also the risk of having of increasing the chances of stroke or heart attack. So if you use Celebrex, there's a 100 milligram capsule and a 200 milligram capsule. However, if you increase it to about 600 milligrams or maybe even a gram a day for weeks and weeks and weeks and months, well, you increase significantly the risk of having a stroke or heart attack. So you don't want to have that risk with Celebrex, like that. So because it's oral and because there's a high chance of having cardiovascular complications if you increase the dosage, you don't want to use Celebrex. Okay, so you just want to kind of stick to topical medication, specifically diclofenac sodium with hyaluronic acid, and that's pretty much it. Yeah. In general, when dealing with skin cancer, after the skin cancer has been dealt with, we have to promote healthy healing of the skin. And to do that, we have to promote the healthy development of DNA within the skin. I'm not sponsored by these brands. I just found these images on the internet. But what we're interested in is actually the product. It's actually niacinamide and niacin. So niacin is actually a form of vitamin B3. So vitamin B3 can have two forms. So you can have the capsule form or you can have the cream form, and that's niacinamide. But why are we interested in taking vitamin B3 for the skin? We are interested in taking vitamin B3 because it helps to create NAD+. So that is nicotinamide adenine dinucleotide. Nicotinamide adenine dinucleotide. And that is used for the DNA to repair itself. So DNA is going to use nicotinamide adenine dinucleotide that is created from vitamin B3 to repair itself. So after we successfully treated the skin lesion, let's say basal cell carcinoma, squamous cell carcinoma, even actinic keratosis, we want to promote healthy DNA repair and development. So we're going to be taking niacin, which is just vitamin B3. So it's available in two forms. You can find them at your local store. You can have niacinamide cream, or you can have niacin capsules or tablets. If you take niacin orally, you have the effective dosage of 500 milligrams twice a day. That's BID. And it's not just a simple dosage. It's not like, oh, you just take it for 2 weeks and you'll be fine. No, really, it takes about a year. It takes about 1 year of taking niacin to really promote DNA replication in healthy cells. So it's about 1 year. And the same is true for the usage of the creams. And an effective concentration of the creams would have to be about a 5% solution. And even better, if you find a product that has niacinamide with combination of retinol. So retinol is another skin product that is a variant of vitamin A, and that promotes healthy skin development. So if you find something with the combination of retinol, it's pretty good for your skin. I will say that retinol will make your skin a little bit more sensitive to the sunlight. So after you use a product with retinol, I highly recommend you use an SPF cream of about 30 or above SPF. So in general, skin cancer can be prevented for the most part if it's just UV exposure. Like for instance, if you're working outside, you want to be using sun lotion that has an SPF rating above 30. You also want to be wearing long sleeves and long pants. You want to wear a hat if you're working in the field, and just protect yourself. Also, there is a possibility of having cancer inside the eyes. So that's a completely different subject. But for instance, melanoma can develop on the skin, but you also have melanin inside your eyes, and therefore you can have some melanoma that has ocular involvement. So always wear sunglasses if you're in a sunny environment, just to protect yourself. And for me, I always found that the best education focuses on not only educating people on the condition and the treatments, but also the prevention of it. So right now you can start using niacin cream, you can take niacin capsules, it's perfectly fine. They're water soluble, so you can't have an excess amount of vitamin B in your system because it is water soluble. If you have an excess amount, then you just urinate it out. It's perfectly fine, and you shouldn't have any complications by taking niacin. And it does promote healthy DNA rebuilding. So yeah, having these nice gel creams, they're really good for your skin, and I recommend it. But I am not sponsored by any of these brands. I just kind of picked the first two images that popped up, so I'm not getting any money from doing this, and it's not a shout out to any of these brands, alright? So don't worry about that. Here we have squamous cell carcinoma. So squamous cell carcinoma can arise from actinic keratosis. However, it is not mandatory to have a previous involvement of actinic keratosis. Squamous cell carcinoma can just occur by itself. So a lot of people think, oh, to have squamous cell carcinoma, you have to have actinic keratosis prior. That's not necessarily true. Actinic keratosis can develop into squamous cell carcinoma, but squamous cell carcinoma can develop by itself without prior history. Here we have a large deposit of keratin protein on the skin. So these keratinocytes have died and they produce a lot of keratin, and we have this large deposit of crust. There is also an ulcer right here, so the presence of an ulcer in this area has crusted over, and because there was an ulcer, that means that this squamous cell carcinoma is aggressive. So we also notice that there are some rolled edges right here. So this it's kind of like a little border right there, but we notice that these edges are raised, and when something is raised, we can say that it is indurated. It is an indurated portion of the lesion. We also notice that there is some redness, and when something is red and it looks irritated, we can say that there is some erythema around the lesion. If you were to pick at this portion right here, it would start bleeding profusely. It is extremely tender to the touch, and it will bleed heavily if it's picked at. For instance, you don't really have to have that keratin deposit for squamous cell carcinoma. So here's another example of squamous cell carcinoma without the obvious keratin deposits. You will notice that it is very shiny and glossy. There's some superficial plaque, some flaking of the skin on the outside. And then we have this nice marbling texture noticed within the lesion. So we have some marbling characteristics right there. And I included this photo here because, it's not always apparent that this is squamous cell carcinoma because there is no keratin deposit. So notice that it's going to have some erythema, some superficial plaque right there. It can have a marbling effect. It could be shiny and glossy and pink, or it can have this keratin deposit and raised edges. So they're usually found in the lower body. So for instance, an area under the lips. So basal cell carcinoma typically occurs above the lips in the face, but for squamous cell carcinoma, you have a high incidence noted in the arms and the legs and torso, on the back even. So yes, it can occur in areas below the lips. There's also a 40% chance of survival rate in 5 years if the squamous cell carcinoma is not treated quickly. So for advanced squamous cell carcinoma, there's about a 40% chance of survival in 5 years. There's also an increased risk of having metastasis for the squamous cell carcinoma. And the reason why we have metastasis in general is because we have a decreased production of something called E-cadherins. So between these cells, there's something that acts like superglue. And this is called an anchoring junction. And anchoring junctions include desmosomes, hemidesmosomes, and adherins. And these anchoring junctions use a protein called E-cadherin. E-cadherin. If we have a decrease in E-cadherin, the superglue doesn't hold as well. So here we have some E cadherins kind of interspersed between the anchoring junctions. And because we have a decrease in E cadherins, the superglue kind of wears off, and now these cells are weakly attached to each other. So they only have like one anchoring junction, for instance. And so now they can easily rip apart and they can travel. And when they travel, they metastasize. So squamous cell carcinoma has an increased risk of metastasis. Melanoma has an increased risk of metastasis. In fact, melanoma is so dangerous, and we worry about it so much because there's an increased risk of metastasis, and it can travel to the brain or to the lungs and cause fatalities. So when you're studying medicine, you have to know that a decreased production of E cadherins increases the risk of metastasis. This is squamous cell carcinoma, and we will immediately notice that there's a halo around the lesion. And in this example, there's an ulcer in the center of the lesion, and it has crusted over. But we have to talk about that halo. What is this halo made of? It's actually a deposit of keratin underneath the skin surface. So you will see a large deposit of keratin protein inside the area of interest. And you can see that here as well. And we have some superficial flaking. It's not really obvious, but it's right here and here too. But you have some superficial plaque of the lesion. Now, for squamous cell carcinoma, it is very difficult to distinguish squamous cell carcinoma with actinic keratosis, and even dermatologists with a dermoscope have a difficult time kind of distinguishing the difference between actinic keratosis and squamous cell carcinoma. And so if you see a lesion like this, or just anything suspicious, it's always a good option to do a biopsy of the area. And whenever you do a biopsy of the area, you will have a clear difference between actinic keratosis and squamous cell carcinoma. So you don't want to let actinic keratosis or squamous cell carcinoma just kind of go untreated, because you want the best outcome for the patient. So if you see something suspicious like this, immediately consult dermatology, or consider doing a biopsy. Here we're looking at squamous cell carcinoma in situ. In situ just means that it is confined to the epidermis. And there's another name that you can give it, and it's actually the proper name. This is called Bowen's disease. And Bowen's disease is only these squamous cell carcinoma located in the epidermis. So it is not infiltrating the dermis as well. So it's not invading the dermis, it is just confined to the epidermis. And you're probably wondering, well, man, this really looks like basal cell carcinoma. It kind of does a little bit, because you do have this palisading effect. It's very obvious right here. You have this palisading effect. And again, this is a lot different from normal histology. So how can we tell the difference between basal cell carcinoma and squamous cell carcinoma? Well, notice, I want you to kind of look at the difference between normal histology and squamous cell carcinoma. So here we have this. We have this. You see this? So this is pathology from Michigan. So we have this. I want you to look at the cytoplasm. The cytoplasm looks nice and uniform. It looks very nice and beautiful right here. And then, boom. What's the main difference? The main difference, aside from the excess amount of keratinocytes, is that we have some glassy appearance in the cytoplasm. I want you to focus on this region. And look at this. The cytoplasm is not glassy. It looks uniform, but here we have little specks of whiteness. We have some clear color in the cytoplasm. And this is highly pleomorphic. Again, pleomorphism just means that the cells are not uniform. This cell right here looks completely different from this cell, and this cell has a different size from this cell. In contrast, these cells kind of look similar. They have roughly the same amount of nucleus to cytoplasm ratio. The nucleus looks the same as this nucleus. It's the same size, but these guys are completely different. The nucleus size right here is different from this guy. This guy is different. They have a lot of whiteness next to them. So for squamous cell carcinoma, you want to look for pleomorphic activity. You want to look for pleomorphism. It has a glassy appearance, in my opinion. So aside from having a palisading effect, you have a glassy appearance. You also have pleomorphism, in which the cells are wildly variable. And that's kind of it. So notice the whiteness right here, and then we're going to contrast that with basal cell carcinoma. So notice basal cell carcinoma doesn't have the white looking cytoplasm. The cytoplasm kind of looks similar to the cytoplasm you see here in normal histology. And compare the basal cell carcinoma cytoplasm with the cytoplasm here. You can immediately see the difference. So normal cytoplasm for basal cell carcinoma, and then the cytoplasm for squamous cell carcinoma. Squamous cell carcinoma has more of a glassy appearance, and it's more pleomorphic than basal cell carcinoma, even though they both have the palisading effect. I also want to bring to your attention the presence of solar elastosis within the collagen of the dermis. And also, we have a lot of inflammation occurring, and we can see that with the lymphocytes kind of building up next to the irritation. So again, we're looking at this kind of grayish, whitish presentation for squamous cell carcinoma. And again, this is Bowen's disease, in which the squamous cell carcinoma is confined to the epidermis and not invading the dermis. And this is invasive squamous cell carcinoma. So notice that you also have kind of like this graying, glassy looking cytoplasm. So that's kind of one of the hallmarks for squamous cell carcinoma. And you're probably wondering, what are these things? This right here is keratinization. So it's actually a deposit of keratin protein inside the dermis, which is actually severely abnormal. And you remember when I was showing you the Dermoscope images of squamous cell carcinoma, and it had that halo, and I said, oh, that's the keratin deposit? That is what you're looking at. Look at this massive blob of keratin deposits. It's absolutely it's severely abnormal, very interesting to look at. It's actually really beautiful if you look at it, but it's a huge deposit of keratin from the keratinocytes. So we have so much keratinocytes being generated because of the lack of p53 and CDKN2A gene expression. So again, we have this glassy cytoplasm from the keratinocytes. And because you have a high concentration of keratinocytes, they start depositing keratin inside the dermal layer. And clinically, you can see that as the white or yellowish halo of keratin. And if you look over here, you have more keratinization. So this is actually the stratum corneum, but because we have a sample with squamous cell carcinoma, you have an excess amount of keratin depositing on the stratum corneum. And look, you also have some parakeratosis because you have some nucleus being found in the stratum corneum. So this is actually very invasive, and you can see that this would have been like the basal layer, but then the squamous cell carcinoma kept infiltrating the dermis, and now it is reaching almost to the subcutaneous layer. So here again, we have the cytoplasm. It's glassy. It's kind of like an ashy gray purple color. You have high levels of keratin deposits, and that's just a really good, beautiful example of keratinization shown by the squamous cell carcinoma, and also parakeratosis. Sometimes you get tissue samples that don't really have this keratinization, so let's pretend that this isn't here, like these red deposits are absent. You would have a lot of invasion. Like right here, you would have some squamous cell carcinoma reaching the deep papillary, not the papillary, but the deep dermis level. So that is invasive squamous cell carcinoma, and with nice keratin deposits. And here we have another squamous cell carcinoma, and again you see this nice glassy color on the keratinocytes, so it's very nice and classy. But notice that there's an absence of any keratin deposits in this sample. So yeah, it's a little keratin deposit right there. It's not that much. You can see that you don't always have to have that heavy keratin deposit to have squamous cell carcinoma. And on this sample, you have some parakeratosis right there. But if we go downwards, we notice that there's not really that much parakeratosis inside the stratum corneum. And we also have a nice keratin deposit, keratin pearl right there. So that is a squamous cell carcinoma, and it is actually invading into the papillary dermis, and it's kind of heading its way into the reticular dermis, the reticular dermis. So that is squamous cell carcinoma. And I want to kind of mention some treatment options for squamous cell carcinoma. This doesn't really apply to this sample because it's such a deep invasion already. If you're dealing with superficial squamous cell carcinoma or Bolin's disease, you can use topical medication. For instance, that imiquimod cream. You can also do 5-fluorouracil. I don't think it's really effective to use that diclofenac sodium with hyaluronic acid. The best option would have to be surgical incision via Mohs surgery, MOHS, or you can do radiation treatments depending on whatever the patient favors or whatever the physician favors. Mohs incision or surgery, MOHS, that's when the plastic surgeon performs surgery on the individual, and the patient is under anesthesia, so they're completely sedated, and they get the lesion and they start shaving it. They start kind of excising it in very thin slices. So let's say that the first slice you have a very large squamous cell carcinoma involvement, and then they keep slicing underneath that tissue, and eventually the amount of squamous cell carcinoma, or really any type of skin cancer, decreases until the surgeon sees that there is no cancer within the area. So of course they would get that skin sample and they would prepare it, they would make slides, and then they can see the involvement of the cancer. So eventually you get to a point where there is no cancer involvement, and the surgeon would stop performing the Mohs surgery. So the reason why this is beneficial for the patient is because you're not taking large chunks of flesh out of the wound, out of the patient. You're taking very thin slices out of the patient's area, and that allows for better cosmetic effect. It allows for faster healing, and it can be used for very sensitive areas. Like, let's say there's squamous cell carcinoma on the ear. Obviously you can't take a whole chunk of skin from the ear. You have to take very thin slices, and the Mohs surgery is a very nice surgery. It's greater than a 95% efficiency for clearance of skin cancer. We will now discuss the clinical manifestations of melanoma inside the skin. To me, it looks like a coffee stain on the skin, and I just don't see any fine blood vessels around the site, so there's an absence of telangiectasia with melanoma. Also, we have to kind of discuss the ABCs of melanoma, and everybody should know this. The ABCs of melanoma. A stands for asymmetry, so there's no symmetry. So really, asymmetry. What do I mean by that? If we were to kind of cut this in half and you fold the left side onto the right side, they would not match. So there is asymmetry within the lesion. Now the B means the borders. So we have irregular borders. Notice that this lesion doesn't really have a nice shape to it. You can't say, oh, that's a rectangle, or that's a triangle, or that's a circle. It's no really good shape for the lesion. So there's no really good borders right there. Now C is going to be the color. So we have irregular color. Notice that the color varies wildly inside the lesion. So this area right here is a lot darker than this area, and this area is a completely different color from this area. So there's irregular color variation inside the lesion. And then finally D is just a diameter. So the diameter is greater than, it is actually greater than 6 millimeters, and that is 0.25 inches in diameter. Really 0.24, but we can round up and say it's wider than a 1/4 inch. And finally, when you're talking about E, there's kind of a debate. Some people say, oh, it's elevated. For me, I like to say evolution or evolving. Evolving. So what do I mean by evolving? Well, let's say that on Monday, the shape looks like this. But then on Friday, the shape kind of looks like that. So we can see that it has evolved to a different shape, or it can actually expand and grow. So if you see a lesion on the skin that has no symmetry, it has a weird border, the color varies wildly, the diameter is greater than a 1/4 inch, and it's always changing shapes, or it's actually growing from week to week, most likely it is a form of melanoma. And you can see another example of melanoma in this individual. So again, we have no symmetry. There's an irregular border, like this. The color varies from side to side, it varies. It's probably greater than a 1/4 inch in diameter. And it was changing from week to week, and that's why it was diagnosed as melanoma. Again, we have a nice example of what is benign, that means non-harmful, and what is malignant, meaning harmful. So if you notice a spot on the skin and it has symmetry or uniform color, or it's smaller than a 1/4 inch, most likely it's benign. But here on the right hand side, we can see abnormalities. We can see that this guy right here has irregular borders, different colors, it's asymmetrical, it's probably greater than a 1/4 inch in diameter. It probably changes as well from day to day. So that would have to be melanoma. We also see more examples of melanoma. So you can pause the video and see what is normal and what is not normal, and how to educate yourself and to spot melanoma on individuals, and to alert a dermatologist or a trained health professional. Melanoma is a bit special because it has 2 growth phases. So when we talk about melanoma, we talk about the radial growth phase and eventually the vertical growth phase. So for a majority of melanoma cases, first you have the radial growth phase, and that leads into the vertical growth phase. But what is the radial growth phase? Well, the radial growth phase is really confined to the epidermis, and it can lightly touch the papillary dermis, but really you have kind of like this spreading of melanoma, and it starts kind of spreading right here, and we can see it's doing it in a nice circular pattern. So eventually it can kind of infiltrate the epidermis. So the radial growth pattern is just when the melanoma is developing and it's confined to the epidermis. Now eventually the melanoma is going to start to infiltrate the dermis. So it begins with the papillary dermis, and it will go into the reticular dermis. And when that happens, we go downwards in a vertical fashion, and therefore that is called the vertical growth phase. Now, a lot of melanoma does that. However, the exception is called nodular melanoma. And nodular melanoma says, I'm not going to do the radial growth phase. Instead, I'm just going to go immediately downwards. So that is very bad. Nodular melanoma is serious. Well, all melanoma is serious, but nodular melanoma is super aggressive, and it has a high mortality rate because it immediately goes downwards into the dermis. The deeper the melanoma gets, the more aggressive it is, and the harder it is to treat. So the deeper the melanoma enters the dermis, the higher mortality rate becomes. And also you increase the risk of metastasis. So as you go deeper and deeper and deeper, you increase the risk of metastasis, and that's when the melanoma kind of spreads to different parts of the body and has systemic involvement. And whenever a pathologist is working on a tissue sample, often they will start staging the melanoma, so they can actually use something called a Breslow, it's called Breslow thickness. And what they do is that they measure from the stratum granulosum, and they can see, okay, well, first we start here in this region, and then it ends here. So, it's X millimeters in depth. So let's say that the melanoma has a depth of, let's say, 0.7 millimeters. So that's the breast lobe thickness of the melanoma. And depending on how deep the melanoma is, there's different treatment protocols. So for instance, this is really confined to the epidermis. However, if we have a thickness of about 1.6, let's say, that is very deep, and it is actually kind of more aggressive. So the deeper we have in breast lobe thickness, the more aggressive the melanoma is, and you would have different treatment protocols for that melanoma. But let's talk about melanoma and metastasis. You should know that one of the areas that is very susceptible to melanoma metastasis would have to be the lungs and also the brain. So whenever the melanoma starts traveling, let's say that there's some lymph vessels right here, some lymphatic vessels, and you also have some blood vessels. Let's make that red right here. So we have some blood vessels. The melanoma is going to go inside the lymphatic system or the circulatory system, and then is going to travel inside the body. It likes to preference the lungs and the brain for whatever reason. For the lungs, you would have pulmonary failure, and for the brain, you would have hemorrhaging. So you would have hemorrhaging. I probably spelled it wrong, but it's fine. So hemorrhaging just means severe bleeding. And so one of the leading causes of death from metastatic melanoma is actually pulmonary failure. The other one would have to be severe brain hemorrhaging, and that is, again, because of the metastasis of melanoma. And so, if it is confirmed that an individual has metastatic melanoma, most likely this individual will undergo a CT scan. So for the lungs, we're going to do a CT scan with contrast. And they do a CT scan of the chest with contrast to see if there's any metastatic melanoma inside the lungs. And that would be a completely different treatment protocol. If it is confirmed that an individual has metastatic melanoma, when we look at the brain, we want to do an MRI with contrast. Why is that? Well, we want to see if there's any bleeding inside the brain. Even if it's a small, tiny, microscopic amount of bleeding, still, that would have to have a different treatment protocol. So MRIs are very sensitive to hemorrhages, and you would do that for an individual who has confirmed metastatic melanoma. So again, they would do a CT scan of the chest with contrast because that individual has an increased risk of having pulmonary failure. And you would also do an MRI with contrast of the brain because, again, when melanoma metastasizes, it often goes to the brain and it causes micro bleeding, and it could cause severe hemorrhaging depending on the individual. So you just want to have kind of like that information in your brain, especially if you start doing rotations in the hospital. You'll say, hey, why is this patient getting a CT scan of the chest? This person just has melanoma. Well, now you know why. You know why these individuals are worried about the lung involvement, especially for metastatic melanoma. And just for reference, just because we're already on the topic of melanoma, I guess melanocytes are really derived from neural crest cells. And you can stain the melanoma when you're doing histology with S100. So it's S100 sensitive. For whatever reason, you have to know that for USMLE, that melanocytes are derived from neural crest cells, and they will stain pretty well with S100 stain. But how do we confirm that this individual has metastatic melanoma? So usually this patient presents with melanoma and it's confirmed, but we have to ask ourselves, okay, is this melanoma metastatic? Because if it is metastatic, it is more aggressive and we have to do a completely different treatment protocol. So what they do is something called lymphoscintigraphy, and I'm going to write it out right now. So this is lymphoscintigraphy. And what lymphoscintigraphy does is that it kind of highlights the first lymph node that accepts lymphatic fluid. So let's say that we have some melanoma right here. This melanoma is going to enter the lymphatic system and then it's going to metastasize to different parts of the body. So what people are interested in is something called the sentinel lymph node. So it is the first lymph node that accepts lymphatic fluid. So if there is metastatic melanoma, and if it is traveling in the lymphatic system, this sentinel lymph node is going to have a high concentration of melanoma. So it's kind of like the guardian of the lymphatic system right there. Depending on the area in which the melanoma is found, a surgeon would start biopsying the nearby sentinel lymph node. But where can we tell where the sentinel lymph node is? Well, let's say that you have an individual that has melanoma right there. If it's on the neck, then it's going to drain into the cervical lymph nodes. If it's on the pelvis, it's going to drain into the pelvic lymph nodes. If it's on the inguinal region, inguinal just means groin, so near the thigh, it's going to drain into the inguinal lymph nodes. If it's on the chest or the torso, it will drain into the axillary lymph nodes. However, in the case of these lymph nodes, there's a high concentration of lymph nodes, so a surgeon can't take all the lymph nodes out and do a biopsy. No, we have to look at the sentinel lymph node, and the method in which we find the guardian lymph node is through the usage of this lymphoscintigraphy. And that what happens there is that they're going to inject a radioactive tracer inside the body next to the melanoma. So the first lymph node that takes in that radioactive tracer is going to be the sentinel lymph node. Now it's important to realize that just because the radioactive tracer was accepted by the sentinel lymph node, that doesn't mean that the individual has metastatic melanoma. No, we're not trying to find metastatic melanoma by doing that. We're just trying to find the first lymph node that takes in the tracer in general. Once that sentinel lymph node has been determined, the surgeon will biopsy that lymph node and cut into it. It then has two options. If you look into the sentinel lymph node and you see melanoma inside the sentinel lymph node, then yes, that person does have metastatic melanoma. However, if the person cuts into the sentinel lymph node and doesn't see any melanoma, then the person does not have metastatic melanoma, and therefore the melanoma has a different treatment protocol. However, a lymphoscintigraphy is not always performed on every individual that has melanoma. You actually have to have a criteria. So the breast low thickness has to be greater than 0.8 millimeters. So if the melanoma is deeper than 0.8 millimeters, then there is an increased risk of metastasis. Specifically, there's a greater than 5% chance of metastasis, and that is clinically significant. So if the breast low thickness is greater than 0.8 millimeters, then the person would most likely undergo a lymphoscintigraphy. And of course, this is only confirmed by pathology. So let's say that a dermatologist realizes that a person has melanoma, they do a skin biopsy, and they send that biopsy into the pathology department. And then a pathologist would actually professionally measure the breast low thickness from the stratum granulosum, and then they would say, hey, it's greater than 0.8 millimeters in depth. And then the dermatologist will say, hey, personally, I think we should do a lymphoscintigraphy. Now, I do have to mention that a lot of people, they consider the lymphoscintigraphy kind of controversial because they say it doesn't increase the survival outcome of patients. And that's really just different opinions from different people. But that's when they do lymphoscintigraphy. So you would only really do it if you have an increased risk of metastasis, and that is greater than 0.8 millimeters in depth. what I am about to explain is very important, and it is tested on medical examinations. So if you learn anything from this lecture, you should kind of take this in your pocket. This right here is actually the kinase family. So we have a kinase family, and if you have any abnormality inside this kinase family, you're going to have some abnormalities that contribute to the formation of melanoma. Personally, I wouldn't memorize what these little acronyms stand for, except for the RAF. So RAF is going to be a little special, and you'll see why, but this is rapidly accelerating fibrosarcoma. And if you have an abnormality inside this subfamily, you're going to have an increased risk of having melanoma. But first, let's kind of memorize just the acronyms in general. And so I came up with something to kind of memorize it. And I came up with map RAS with RAF with me, okay? If you don't, that will irk me. And maybe English isn't your first language, but irk just means to bother something or to bother someone. And for this mnemonic, I guess, this memorizing strategy, me, K, so I just put okay, but there's no O. So just map RAS with RAF with me, okay? If you don't, that will irk me. And personally, that works for me. You can make your own, but that works for me. So on an exam, if you see any of these acronyms, most likely you're going to be talking about cancer, because cancer derives a lot from this kinase family. And what these kinases do is that normally in a healthy system, they have cell signals that signal for the creation and the destruction of cells. So for instance, we have this cell communicating with another cell, and we have another cell right there, and they're going to start causing these signals right there. And these signals are actually phosphorylation cascades. So you're going to have these little molecules phosphorylating each other, and if a cell receives these phosphorylation signals, it can either replicate itself or it can be signaled to have cell death. So in a normal healthy body, the kinase family doesn't have any abnormalities. However, when a person has cancer, most likely one of these families are mutated, and they send too many signals for proliferation and not enough signals for cell death. So that therefore you have an accumulation of cancerous cells inside the body. So again, you have these abnormalities found in this kinase family. It's MAP, RAS, RAF, MEK, and ERK. And when we talk about melanoma, we have an abnormality inside the family of RAF, rapidly accelerating fibrosarcoma. And specifically, there's a subsection called the BRAF, and you have to know that. When we talk about melanoma, there is a mutation in the V600E portion of the BRAF. So what does this mean? Well, there's a mutation, and there's a codon. So this codon has 3 little amino acids, and on this codon we have, amino acid, let's say E. Right here you have the replacement of glutamine, and instead you're going to replace it with valine. So you have these amino acids. This is a healthy BRAF gene, but now you're going to mutate it, and you're going to replace glutamine with valine. So now you have a amino acid, and then valine. So this is all that we're saying. When melanoma is determined, it can have a specific variant. So a majority of melanoma is going to have this BRAF V600E mutation, meaning that we took out glutamine and we replaced it with valine. Some melanoma, when it is determined, we determine what type of melanoma it is. Some melanoma has a variation like this, BRAF V600K. And that's not common, but it does happen. And here, this is replacing lysine with valine. So valine seems to be the offending mutation for the BRAF mutation. Now, BRAF is not just confined to melanoma. You also see that with colorectal cancer, and you always see that with hairy cell leukemia. So 100% of the time, you will always see a mutation in the BRAF gene when you're dealing with hairy cell leukemia. And you will always see a mutation with the BRAF gene when you're dealing with melanoma. When we're dealing with cancer, let's say melanoma or even colorectal cancer, you have some abnormalities in the phosphorylation cascade with the kinase family. So here we have some growth factors right there. So the growth factor is going to press this button, and the button is going to release RAS. And then RAS is going to interact, it's going to phosphorylate the BRAF family. Now the BRAF would normally communicate with MEK, and then MEK communicates with ERAK, and that increases proliferation. And then normally it would get a signal to stop proliferation and induce apoptosis. However, when we have a mutation in the BRAF family, let's say that we have the V600E mutation and the V600K mutation, then we would have too many signals going into the MEK family, and that increases the proliferation of cells and it decreases the apoptosis of the cells. So we can see that this is a very bad combination. We have to find a way to block the BRAF complex. How do we do that? Well, we can use certain medications. For instance, we can use a medication called vemurafenib and dabrafenib. We also have something called rafenib. And I want you to kind of look at the name. Each name has something called RAF and dabrafenib, rafenib. Each one of these medications have RAF in the name, and therefore whenever you see those medications, you can kind of look at it and say, hey, I know they're going to be blocking the RAF family, the rapidly accelerating fibrosarcoma family. And a part of this family is the BRAF subfamily. There's a mutation in the BRAF subfamily that increases the risk of having melanoma. So if you can block the BRAF family, you're going to block those signals for the MEK family. And if you don't have those signals, then you stop the cell proliferation, because really BRAF is kind of like the gas pedal for cell proliferation. If you have a mutation and you keep communicating with MEK, then you keep telling the body to make those cancerous cells, and the body doesn't want to induce apoptosis. But if you can stop the communication from BRAF with MEK, then you can decrease the amount of cells being produced, and you can increase the amount of cells being destroyed via apoptosis. Also, I just realized I misspelled encorafenib, so it's actually encorafenib. So just keep that in mind. Encorafenib, vemurafenib, and dabrafenib. Vemurafenib was introduced back in like 2011. It was one of the first medications that was FDA approved to treat melanoma, specifically the V600E mutation melanoma. I also want to point out that if an individual just uses vemurafenib by itself, there's an increased risk of having drug resistance over time. What does that mean? Well, if a person just uses vemurafenib, eventually it stops having the same success rate. So eventually the body kind of bypasses the medication. So for some reason, the BRAF family will still find a way to communicate with the MEK family. And that's not good, because that increases the risk of having that melanoma. And so the treatment fails. Therefore, usually a person is prescribed both a BRAF inhibitor and also an MEK inhibitor together. So for instance, a person would be using vemurafenib, and in addition to this, they would be using trametinib. And trametinib is just an MEK inhibitor. So in case the BRAF find a way to communicate with MEK for whatever reason, we are now blocking the MEK family using trametinib. So usually a person would have a BRAF inhibitor in addition to the MEK inhibitor. It's important to realize that when a person is taking a BRAF inhibitor, that person also has an increased risk of developing squamous cell carcinoma. That's why it's very important to physically assess the patient when they are taking BRAF inhibitors periodically. Periodically assess their skin to see if there's any development of squamous cell carcinoma. If there is development of squamous cell carcinoma, most likely that patient will not stop the BRAF inhibitor. Instead, they would surgically excise, they will surgically remove the squamous cell carcinoma and continue the BRAF inhibitor. The only reason why a person would stop the BRAF inhibitor is because there is a severe development of melanoma, or there's a severe allergic reaction to BRAF inhibition. Another risk of taking BRAF inhibitors is that there's a prolongation of the QT wave. So in the heart wave kind of looks like this, and then looks like that. So that's what a normal heart rhythm looks like. But with a QT wave prolongation, the QT wave would instead look like this. So we have this right there, then we have this, and then it's going to prolong, and then T wave. So again, that is kind of like a exaggeration just for you to learn. So here, this portion, this is where the Q begins, and this is where T happens. So notice that there's a greater distance between the Q wave and the T wave. So that is QT wave prolongation. And that is a risk of taking BRAF inhibitors. Another risk of taking BRAF inhibitors is that it is very rough on the liver and also on the kidneys, and also on the heart, as you just seen. So before a patient is started on BRAF inhibitors, they would have to have a renal panel performed, a hepatic panel, hepatic function panel, renal function panel, and then a EKG. So for here, you want to do a renal panel, and then a liver function, and then you want to do an EKG. And that is before the patient is placed on BRAF inhibitors, and that allows the medical team to see kind of like the normal values of the patient before the medication is introduced. And periodically during that course of treatment, maybe once every month, they would have another repeat test for these values. And if you see something is depressed or something is elevated, then the medical professional team can act accordingly. So before a patient is placed on BRAF inhibitors, they would have to have their liver tested, they would have to have their kidneys tested, and then perform an EKG just to see the normal values before the medication was introduced. What you're looking at is melanoma, and melanoma is very invasive. And what you should be kind of worried about are these melanoma nests. So melanoma likes to kind of make circular deposits around here. So we can see that there's a circular deposit of melanoma. Here are the little melanocytes kind of congregating right here. So we can see that they have like this dirty looking cytoplasm, looks like dirt. And we have a very, very fine mist of gray cytoplasm for these melanocytes. You can see it here interspersed between the keratinocytes. So here's a nice difference. So here's a keratinocyte, and it has a nice darkly stained cytoplasm, and right next to it are the melanocytes. So the melanocytes have this kind of ashy white cytoplasm, and they like to form circles, they like to form nests. And it's very rare that you see full thickness involvement of the epidermis with melanoma. So you don't really see involvement of full thickness epidermis with melanoma. So again, here we have more melanoma. You can see that they have kind of like this nice spider web, gray looking cytoplasm. Here is another example of melanoma, and you can see that this is severely metastatic. So it is like it's invading the dermis. And you'll also notice, hey, there's a lot of tearing right there. Why is this area so fragile? Well, the more melanoma you have, well, I guess the more melanocytes that you have, the more abnormalities will be for that E-cadherin. So again, E-cadherin is a protein used by those anchoring junctions that promote cell adhesion. And the more melanocytes there are, the more weak that E-cadherin becomes. So whenever there's more melanocytes in this area, the anchoring junctions weaken and they are very fragile, and that promotes metastasis for that melanoma to go into a blood vessel or lymphatic vessel, and then it's going to go to the brain or to the lungs. So because you have so much cancerous cells development, you have a decrease in E-cadherin. So that leads to the fragility of this tissue, and we can see that it is just tearing through this tissue. We also notice that ashy gray cytoplasm, and this is an example of pleomorphism. So you can say, hey, this is atypical melanocyte presentation. We have some pleomorphism, some marbling effect noted inside of this tissue. You also can see some melanin deposits right there, but I want you to kind of look at the nucleus, and the nucleus is surrounded by this ashy spiderweb gray color of the melanocytes. So that is really invasive melanoma. So that is very invasive, and again, you have these melanoma nests where it kind of looks like an egg or a nest of just melanoma, and it's setting up shop deep into the dermis, and it's almost reaching the other side of this region. It's ridiculous. We can see some pigmentation right there. Also, I just wanted to point out, because we're not involving the upper epidermis, we will not see any parakeratosis in the stratum corneum, so there's no reason why there would be nucleus or nuclei inside the stratum corneum. And I would say that this is kind of like the vertical growth phase. So initially it was starting in the epidermis, and that was the radial growth phase, and now it's invading the dermis, and this is part of the vertical growth phase. So it's going to continue to kind of invade the dermis as it goes vertically downward. Here we have a great example of nodular melanoma, and nodular melanoma is very aggressive because it skips the radial growth. So instead of just hanging out in the epidermis and kind of growing circularly, it goes directly to the vertical growth phase. So now it kind of starts at the epidermis and it starts digging downwards immediately. So you can see that this guy right here is digging downwards towards the dermis. So this is nodular melanoma, and it's very aggressive. And there's a completely different treatment protocol between different types of melanoma. So like superficial melanoma and nodular melanoma have different treatment protocols. Again, here you have this melanoma nest, this little island or node of melanoma, and it's setting up shop right here, and it's gonna eventually start to go down deeper into the dermis. As you can see here, you can see some infiltration of the melanomas, or of the melanocytes protruding. And then here you can see some melanoma trying to go into the dermis, and then the immune system doesn't like that, so you have these little dots right there, these lymphocytes, and they start attacking the melanocytes because the melanocytes are trying to go deeper into the dermis. So I also kind of want to mention a really nice characteristic of melanoma that you can use to look at melanoma in histology, and that is the pagetoid spread. So when you're looking at melanoma, you'll notice that some areas have this weird artifact, this weird gap of white space right there, and some glassy color, and some more white space and more white space. So it looks like little glass beads inside the slide, and that is called pagetoid spread. So it looks like somebody got a shotgun and shot the area with pellets, and you have these little pellet formations in melanoma. So that is pagetoid spread of melanoma right there. So it involves the basal layer of the stratum basally. And also realize that we have some solar elastosis right there, and then we have some spreading of this pleomorphic melanoma. So we have some pleomorphism being exhibited by these melanocytes. So we have some nice irregularities between the melanocytes, and they are invading. And if we keep zooming out, we have this huge node, and it's just ridiculous how large this melanoma can be. So you can see that you have this ashy, grayish white cytoplasm and an abundance of melanocytes, and that is very invasive, and it's forming this node of involvement. So it is very aggressive, and that's why we treat melanoma so quickly, and we treat all skin cancers with seriousness and with respect. And here is an actual slide of the eye. So again, we do have melanin in our eyes. However, that does have the risk of having melanoma. So this is ocular melanoma, and you would have to have a huge team of just ophthalmologists. You would have to have oncologists, and it's just a different treatment protocol, and it's just rapidly spreading inside this eye. It's very sad to look at. You have so much melanoma right there, and it's just very sad. Yeah, so you can see just dark pigmentation right here. So that is ocular melanoma. And before I forget, when a person uses 5-fluorouracil, in general, that also increases the expression of p53. So now the body has enough p53 to induce cell apoptosis for those malignant cancer cells. And that is, before I end the video, I just wanted to mention that. So hopefully now you understand how to look at skin and to say, hey, I suspect melanoma, this kind of looks like basal cell carcinoma, this looks like squamous cell carcinoma, and now you know what it looks like under a slide, and some different medications, how those medications work, the contraindications, side effects, precautions, and just so many great things. So thank you so much for watching this video and spending your time with me. I love you. You are awesome. And you know what? I'm just so happy we're going to do both of my little guys. So I'm just like, oh, I'm so excited. This was awesome. Like, just teaching dermatology and dermatopathology. I'm not an expert or anything. I'm just a medical student. But I love teaching, So hopefully when I grow older and I become a professional, I can continue to teach, because I really love teaching. I don't know what I'm going to be or what I'm going to specialize in, but hopefully I get to continue being an educator, because I really love what I do, and I love educating. And hopefully you love this video and you're inspired to study even more. So thank you so much for watching this video. Remember that I love you and that you are awesome. So again, have a great day and stay safe. Bye.